Good afternoon to all, and welcome to the IC on Medical Retina Mysteries. We hope to show some light over the difficult questions that we face in the clinic every day. We've kept the presentations very short with very little material in it, mainly to incite a discussion. So we hope the audience will also be interactive and discuss with us. So first we'll go to one common thing that we see in our clinic, CSCR, the problematic commoner, by Dr. Suchitra Bhatt, retina consultant at Netra Jyoti Advanced Eye Care, Taliparamba.
Good afternoon, all. At the outset, I would thank Dr. Natasha Madam for giving me this opportunity. CSCR is one of the fourth most non-surgical maculopathy in the eye. It is the most simple disease, but it's one of the most complicated disease. Today, as we are moving towards the pachychoroid spectrum, I'll be concentrating more of the simple facts which we are forgetting as we are moving to the pachychoroid era. First, my sincere thanks to my regards to my mentor, my father-like figure, Dr. Baby Bhatt. So moving on to the first case, she's a 51 years female. She's a very close friend of mine. She presented to me with diminished vision of left eye since 2 weeks. She had an history of using nail cream plus some face cream for 2 weeks and a history of some sleep deprivation due to night party at home. She has alcohol once in a week during parties, and her visual acuity with +4 in right eye was 6.6 and 6.24 in left eye, and near vision being N8 in the left eye. Amsler's gait was distorted in the left eye, and she had a history of YARC PI done 5 years back. Anterior segment was normal, both eyes, and the right eye showed angioid streaks infratemporal to disc. This is the left eye of the patient, which showed typical CSR with angioid streaks, if you observe carefully, infratemporal to the disc. I asked her to stop the cream and come after 2 weeks, but still CSR was persistent. Not 2 weeks, actually 1 month, and she was very tensed about that, so I thought I'll do the FA immediately. So this is the FA of the patient, which showed a typical ink blot leak, which was very much away from the fovea. So I did the focal laser immediately. So this is after 2 weeks after doing laser, and this is after 1 month after doing focal laser, where she has completely resolved CSCR. So what was different in this case? So there was a hemorrhage in this case, which is very rare in a CSCR. Hemorrhage is very rare in CSCR, but it can occur as I went back and studied. It may be due to the abnormal blood vessel leakage or due to the high pressure in these fluid collection. This can cause disruption of the blood vessels, or it can be due to rib tears, which is secondary to CSCR. So hemorrhage in this case, it can also be due to angioid streaks due to the brittle nature of the Brooks membrane. So was the skin cream responsible for her CSCR? So I asked her to get her skin cream, which showed the content like glutathione, kojic acid, arbutin, vitamin C, etc. did not contain steroids. But as I discussed with my nephrologist, I came across these. Though these skin creams show these contents, actually they are finding out many cases which contain high doses of clobetasol, arsenic, and mercury. So I went back to the case and saw whether the skin cream was responsible for CSAR. She is a very non-anxietic patient, not a type A personality, happy patient. Will the alcohol or sleep deprivation would have caused a CSR? No, because she's been following up with me for past 2 years, and she's continuing with the same life routine, and she didn't have recurrence. So I discussed with the dermatologists also, and they also told me the same thing. So there are some of the skin creams which these are some of the depigmentation creams which most of our patients are using, and which might have caused the CSR. I don't know whether I can tell confidently, but the creams which I got through the dermatologist, my patient was using the Vita Glow cream. So I have an experience of around 10 patients who are using some skin creams which does not show the steroid content, but they are developing CSR. I just wanted to highlight this. Whenever you come across a CSR patient in your clinic, just stop any depigmentation creams they are using. So these depigmentation creams are very addictive. They give immediate results to the patient, and once they stop and they become dark again, and again they start using. So better always to avoid this patient, and we need more studies to prove. If anyone has the guts and bold to go across these companies, we can work on it better. So this is my second patient. She's a 46 years female patient. She came with diminished vision left eye since 2 months. She has no systemic illness, very, very anxietic patient. She doesn't have any positive history of any medications, creams, inhalers, etc. Visual acuity in the right eye was 6.6 with correction, and left eye it was 6.6 partial. So this is the her fundus photograph and OCT, and left eye shows lot of fibrin. Since she was very anxietic, and this is the right eye of the patient, which is asymptomatic, but still there is fluid there, which also shows a CSR. So since it is a bilateral CSR, I immediately did the FFA, and this is the typical ink blot beak in the left eye, which is almost inside the FAZ, and this is the right eye of the patient with the typical leak and lot of RP disturbances. So I convinced the patient to do the focal laser for the right eye, as there was lot of RP disturbances, and it was very safe to do as it was away from the FAZ. Left eye, I just gave NACDs, and I gave melatonin tablets for 1 month. So this is the right eye of the patient after 1 month, fully resolved CSR. And this is the left eye of the patient, which is also resolving, though there is fibrin, which is a poor prognostic factor. So one of the new things which I have found recently is that melatonin do helps in CSCR patients. It as I went back and studied, it's known to be linked to circadian cycle, and it regulates sleep. It is an antioxidant. It has an inhibitory action on corticosteroids. It helps patient if given at bedtime. So any CSCR patient, when you see when they are very anxietic, when they have sleeplessness, it is better to give melatonin at bedtime. You have nothing to lose by giving this. Improvements I have seen in around 30 to 50 patients. Maybe CSR is a self-limiting condition, but patients have a feel-good factor, and they have less anxiety. So since this has less side effects, there's nothing to lose by giving this. So this is case number 3, where a patient has diminished vision both eyes since August 2023. She's a post-kidney transplant patient. She's on Visolon 10 mg since 1 year, and she cannot stop oral steroids as advised by nephrologist. So visual acuity was right eye was 618, left eye was 6.6, and dropped to 5/60 and 4/60 gradually. That was because of the post-subcapsular cataract, which we operated. And of post cataract surgery, her vision was 6.9 and left eye was 6.9. So this is the right eye of the patient since 2023, and 24 long standing CSCR in the right eye, and left eye also has developed CSCR. So how to manage such patients? We can't stop oral steroids, and how to go about it? Now there are many studies which show that intravitreals will help in CSCR patients. I personally don't have any experience. If the panelists or the audience have experience, we can go about it, or how to manage this patient where we cannot do a FA, she's not willing for Octa, we cannot stop steroids.
Very interesting cases, Dr. Suchitra. Let us, shall we move backwards from this one? So in a bilateral CSR, I think and you already have a history of steroid intake, you cannot stop the steroids, then you have to get an FA done, because that is the only way to deal with them. You have to find out the leaks and do a CSR laser wherever possible. Some leaks may be very close to the fovea, but whatever is away from the fovea should be lasered. We can also give a note to the treating physician that this is there, so they can reduce the dose to as minimal as possible to whatever. Most of them do that, or they sometimes shift over to some steroid sparing agent, because we can tell them that it will affect in the long term, affect their vision, and they usually do switch. So that is the only thing. Intravitreal anti-VEGF, no, not for CSR unless there is a secondary CNVM for which the patient can. There is no features in this patient. I would suspect one in your previous patient, but not in this patient. There is no evidence of any CNVM here. So here we are dealing with a systemic problem that has caused the CSR. So at best, we have to manage the tightrope between the steroid intake and the CSR. About melatonin, no, can we go to this case is here. Show me that OCT, please. Yeah, here you can see that there is a definite small serous PED and that irregular RP there, fibrin there, because we know from previous scan that there was fibrin in the beginning itself. So that is definitely fibrin. But if it is not resolving or if there is intraretinal fluid, I would ask for an octa for this patient because you may be missing a long chronic CSRs can produce CNVMs and you may be missing that, and treating just with placebos when the patient actually requires intravitreals. Melatonin, I personally have not given to any patient, but it is a non-addicting sleep helping drug that is now freely available and can be given in a low dose. Yes, if you have a good rapport with your patient, generally I try to avoid antidepressants and such things from our side. If you think the patient is anxious, they should go to a specialist and get the anxiety sorted out than us giving something. From our side, we can give our placebos and not the other one. If you have a good rapport with the patient, yes, melatonin is a safe drug that you can try. Face creams, just to be, you've just scared me now. What about all my anti-aging stuff that I slather on? And the husband says that I'm poisoning him. Yeah. So, yes, I routinely ask for face creams because a new onset face cream use and then CSR, because a lot of absorption through the skin. Even other creams like eczema, everything should be asked for. The first CSR patient who comes into you, don't just dismiss it as CSR. You should ask them, what have they started using recently? Any Ayurvedic medication, any skin cream, face or otherwise. Sometimes they put for, thick skin or like hyperkeratosis somewhere, and then that is a steroid cream. So you can ask in detail history of that. Ask them to stop it. That will help you in managing your steroid patient.
Yeah, this is just a summary, but one new thing I want to tell is there is a new concept called as familial CSR. We have to think more about this. Studies have shown that where the siblings are developing CSCR, and I had a patient where husband and wife both developed CSCR simultaneously. So we have to think in that direction.
Causing mutual stress.
And the husband developed recurrence after 6 months. Luckily, the wife didn't develop recurrence. So,
Shall we take doubts from the audience?
yeah, any questions?
Okay. You can fit the last slide.
Yeah. So this is just, I just want to highlight, as we are going to more complicated things, octa and this thing, don't forget to have a chair time with your CSCR patient. It is very, very important. Even crash diets, jet lag, lack of sleep, any infection, for example, it's a stress for the patient. So always don't send it to your counselor or this thing. You yourself talk to them for 10 minutes and then send. That makes a lot of difference. So any questions?
Any doubts from the audience? I think we have a record audience here. We should take a picture. But I'm so sorry that you don't have seats. Can the hall management do something about it?
There are some seats in
We still
between.
have 1 hour, no? Some more extra chairs, maybe even just plastic chairs.
Here, there are
Any doubts? Anything that you encounter in your this is like this is just a simple session. Nobody is going to judge you. You can ask anything. Yes. No, again, indomethacin and other NSAIDs have no proven role in CSCR. The pachychoroid spectrum is what is causing it. So they are actually prone to develop from both the choroid side and from their mental side. So that is what is causing it. Eplerenone, yes. For chronic, for CSRs that are not resolving in 3 months, I usually do a FA. And if the FA is, we cannot do the laser, then I do try eplerenone. It is not a panacea. It doesn't work in everybody, but it works in some people. So you can try that, monitor your RFTs while you're giving. So if you're giving it for more than 2 months, definitely get an LFT, RFT done when you're giving that. It is like a spironolactone kind of diuretic. So you need to be aware of that when you're giving. But you can give, I usually give 50 mg OD eplerenone. Then any other drug, what do I give when a patient comes with CSR? Anybody can guess? Yeah, just the usual placebos that we give in our ophthal OP and tell them that it will cure. That is more important. Give them confidence that it will go away. So don't tell them that, oh, idinu marunonnum illa. And that will just stress them out even more.
One more thing is we have to explain is contact sensitivity comes back to normal only after 3 months. So patients keep on complaining. So tell them that it takes 3 months for the, even though the CSR is resolved in OCT, it takes 3 months for the contact sensitivity to come back to normal. So just explain so they'll understand.
And always tell them that it will resolve, especially first timers. Just give them some give in your plethora of the antioxidant drugs that we have, you can give. But whatever you give, you tell them that idu kadicha madi oru masam maarikolum.
There are some seats in the front room.
I usually call back after 1 month. No. See, first episode CSR is not going to cause a CNBM. It is going to go off. And recurrent CSRs, or if you see any change in the CSR, the things that you have to be conscious about when you're following up a CSR patient is there intraretinal fluid. Intraretinal fluid is a sign, one, of chronicity. It can be there without a CNBM, but you have to suspect a CNBM. And also if the RP is irregular and it is showing signs of fibrovascular PED.
Yeah, ma'am, I have a doubt. What is your experience in giving spironolactone for recurrent CSR?
As in the spironolactone?
Yeah.
No, I have not given. I have given only eplerenone.
And how is it? How is it working?
Eplerenone works. That's we answered that question before. It works in some people, does not work in others. Don't continue for a long time if it's not working.
Okay.
Try for 2 months. If it's not working, you can stop.
Eplerenone helps more in patients who has fibrin and such biomarkers. So better to start in such patients. So when you have fibrin, eplerenone is known to work better.
And what appears to be bilateral CSR, again, FA is very important because in a bilateral CSR, you may be looking at something that is not CSR at all. So it may be just a multifocal CSR, but it may be an early VKH. It may be a paraneoplastic syndrome that is causing. It may be TB. So do not think that all SNDs are CSR. So SND, any atypical feature, especially multilocularity and bilaterality, has to be investigated with a fluorescein angiogram. Yes, Suchitra.
Yeah, I give it for 3 months usually. Yeah. So, dose is 3 mg of Mactone. You get these multivitamins tablets. One of the tablet I give, I don't have any personal interest, MacuGold Plus, which has melatonin plus all the other antioxidants in that.
Oh my God, they're going to give you something. Yes. Now the conventional thinking of, you wait for 3 months and then only do FA, all that is changing. You can do FA if it's a large CSR or even a small one in a patient who wants faster visual recovery. There is no harm in telling them that we can do an angiogram, find out where the leak is. If it is laserable, we can laser it. Should not say that, okay, namukadu cheyyam parayanda, but at least you can tell them that, let's see. Especially these IT professionals who really can't work with that CSR. So you can do an early FA if it is not resolving. I think we should stop and move on to the next talk.
Just one slide. We just want to invite everyone for the CME on uveitis, which is on January 4th and 5th. Please do come.
Here in Kochi, jointly organized by 12 of us from Kerala. So next I invite Dr. Neetu Pradeep for her talk on the black sheep in the AMD spectrum, RAP.
A very good afternoon to all. First of all, I thank KSOS and Natasha ma'am for giving me this opportunity. So today's discussion is about RAM, a black sheep in AMD spectrum. The first case is of a 69-year-old female who presented with gradual painless defective vision in the left eye. She gives no systemic history. The best corrected visual acuity is in the right eye is 69 parts with an immature senile cataract, and fundus showed dry ARMD changes. The best corrected visual acuity in the left eye is 636 parts with a pseudophakia, and the fundus examination of the left eye shows normal disc and vessels. And in the macular region, if you see carefully, you can see a shallow PED, intraretinal exudates and hemorrhages. So in the autofluorescence, there is hypoautofluorescence corresponds to the exudates and hemorrhages. And in the multicolor imaging, if you're seeing, there is a retinal arteriole which is coming. There is a retinal arteriole which is coming into the network, and a retinal venule which is draining from the network. So this is the OCT of the eye, which showed a PED and intraretinal fluid. I'll discuss it more. So you can see the foveal contour of the eye is altered. There is intraretinal fluid, the intraretinal exudates, a PED with disruption of RPE at the apex of the PED with a homogeneous hyperreflective material corresponding to a network. Beneath the PED also you can see hyperreflective material. So we did an FFA ICG for the patient. The FFA ICG in the face shows a hyperfluorescent dot which is seen at the termination of a retinal vessel, and the fluorescence increases over in the late frames. And in the late frames, we can see a draining venule from the hyperfluorescent spot and increase, and there is diffuse leakage. So, in short, the FFA showed a draining arteriole, a hyperfluorescent hotspot, and a draining venule, and ICGA showed a hotspot with a sudden dipping of the retinal vessel. So, patient underwent intravitreal anti-VEGF aflibercept. So, this is the pre-injection and post one dose of Eylea. After first dose of anti-VEGF, the intraretinal fluid has decreased, and when the patient came for follow-up, the visual acuity has improved to 624, and we again advise for the second injection. So, post second dose of Eylea or aflibercept, the height of the PED has significantly gone down. The IRF has completely resolved, but there is some network which is still seen in the OCT. So, this is the OCT post Eylea second dose. So, you can see the PED has come down, but there is still some network. The visual acuity improved to 612, and the patient underwent third dose and is awaited for follow-up. So this in summary, so this was the initial OCT. This is post 2 doses of aflibercept. As you can see, that there is significant improvement in vision as well as in OCT findings. Case 2 is of a 76-year-old male who presented with defective vision in right eye. The best corrected visual acuity was 660 in right eye, and left eye is pseudophakic with dry ARMD changes. The fundus photo of the right eye showed macular exudation with intraretinal hemorrhages and fluid. The autofluorescence confirms the findings, and OCT first visit shows intraretinal fluid, hyperreflective material which corresponds to the network, subretinal fluid, and a shallow PED. This patient also underwent a FFA ICG. So here also we can see a hyperfluorescent spot or a hotspot at the termination of a retinal vessel, and there is late leakage. The patient underwent intravitreal injection ranibizumab. Post intravitreal anti-VEGF first dose itself, the IRF has gone completely, and there is only hyperreflective material is remaining. However, when we saw the patient clinically, there were still exudation and hemorrhages. So we repeated the dose of anti-VEGF, and post anti-VEGF third dose, the visual acuity improved to 612. The IRF has gone completely, and the exudates has also decreased considerably. So this is the summary. When the patient came, his visual acuity was 660, and post 3 doses, his visual acuity has improved to 612, and the patient is really happy. So what is this? From the fundus, we can see superficial intraretinal hemorrhages, exudates, and a PED. Whenever we see these three findings, it is pointing towards RAP or retinal angiomatous proliferation. So, other findings what we can see is retinochoroidal anastomosis or reticular pseudodrusen. So, RAP is a distinct form of ARMD, which is otherwise called as type 3 CNV. What happens in the in normal age-related macular regeneration is that the neovascularization starts from the choroid, it reaches the RPE and then goes into the retina for forming a choroidoretinal anastomosis. But in RAP, the reverse happens. That is, the neovascularization starts in the retina and it moves to the choroid. This is also known as deep retinal vascular anomalous complex or retinochoroidal anastomosis. There are three stages. Stage 1 is intraretinal neovascularization, where the IRN arises from the deep capillary plexus, and clinically we can see it as intraretinal hemorrhage or a mount or a nodular mass. In stage 2, what happens is this neovascularization extends to the photoreceptor layer, forming a subretinal neovascular network, and it is associated with neurosensory detachment. Retinoretinal anastomosis with a draining with a arteriole and venule can be seen, and this communication resembles a hairpin lobe. Stage 2 subretinal neovascularization, that is, it may or may not be associated with PED. So when the neovascularization reaches the RPE, the PED is formed, and FFA at this stage can be mistaken for hotspots of occult CNVM. ICG in this stage also show hotspots. Stage 3 is choroidal neovascularization. That is the final stage of a stage with retinochoroidal anastomosis, and ICG showed the presence of choroidal neovascularization. FFA is useful only in the diagnosis of early RAP lesions. Late stages can be confused with occult CNVM. ICG shows hotspot in mid and late frames. Hairpin loops can also be appreciated, and it can also reveal the retinochoroidal anastomosis clearly. What is the difference between the typical CNVM and RAP? The patients in RAP seems to be much older, and mostly it is intraretinal hemorrhages. The subretinal bleeds are relatively rare in RAP, and usually it is seen at the parafoveal area and not at the fovea. So management options, it includes anti-VEGFs, ablative methods, and combination treatment. Going to one of the major trials, which is CAT trial. CAT trial in RAP says that the incidence of RAP was around 10.7% in the normal population, and it says that at 1 and 2 years after anti-VEGFs, the outcome is really good, and RAP responds much faster to the anti-VEGF than other forms of AMDs. Differential diagnosis includes IGT, PCV, CNVM, and macular BRVO. So take-home message from this talk is that in all cases of PED with exudation after PCV, after 50 years, we should rule out RAP and PCV. And whenever there is intraretinal blood, exudates, and a PED, the diagnosis is more in favor of a RAP lesion. So I would like to ask a few questions to the panelists. First is, what is the role of ablative methods, including the latest micropulse laser, madam?
So I think we'll go to the diagnosis first because that will be more important for the audience. Let's go to that OCT picture. The previous case, first case. Yes. So the one thing we can remember from this picture, whenever we do an OCT in a CNVM, the underlying RP is always disrupted. So here you can see that the Bruch's membrane is nicely seen. It is more like a straight line. There is no disruption there at all because the CNVM has not grown from below. It is growing from above and it is becoming a CNVM. It has not become a CNVM yet. So the presence of intraretinal hemorrhage without subretinal hemorrhages. So subretinal means that there is definitely subretinal CNVM. So here presence of intraretinal without subretinal component at all. You can get intraretinal in CNVM. That's why I'm specifying that, because in a CNVM you can get both intraretinal and subretinal. But if you just get intraretinal without subretinal in what appears like a CNVM, then you have to suspect that it is a RAP. And the one investigation that helps us a lot, FA helps in the early stage, ICG helps, OCTA. OCT angiography can very nicely pick up this RAP lesion, that vessel that is actually growing into the retinal layers. That is can be very nicely picked up on OCTA. Treatment, I am like, the study seems to show that it responds nicely to anti-VEGF. All the RAPs that I have, I'm literally eating my head because it goes down nicely, but it comes up immediately. That is my experience with RAP. So if you stop the anti-VEGF, it will come back. So you have to tell them that they're in for a long haul with this treatment, that they will require as and when needed multiple anti-VEGF injections. It will respond nicely in the beginning, but it will not dry up as much as, or die off as much like a choroidal neovascular membrane. About micropulse, I don't have micropulse. Is there anybody in the audience who has used micropulse for RAP lesions? I don't think so. So we'll leave that question out. Yes, anti-VEGF is the way to go. Anti-VEGF treatment, any of the anti-VEGFs you can use. The higher the anti-VEGF has better results, but everything needs to be repeated. RAP cannot be treated with reloading doses. It will come back. Any doubts from the audience? Thank you, Dr. Neetu, for your presentation. If not, we'll go to another very common condition that we see in our clinic. CRVO in the young, can we help them? By Dr. Parvati R.
Good afternoon all. Today I'll be presenting a case of a 37-year-old lady who is a teacher, presented on 22nd of October with sudden onset of defective vision in the right eye, 2 days duration. It was painless progressive. There was no previous medical or ocular history. She had history of anemia 8 years back during her postpartum period and it was treated. And on examination, the affected eye best corrected visual acuity was 6.9 in 8 and left eye it was 6.6 in 6. Anterior segment examination and intraocular pressure were normal in both eyes, and fundus examination of left eye was within normal limit, and right eye showed a mild disc hyperemia with dilated tortuous retinal veins with peripapillary flame-shaped hemorrhages and multiple blot and dot hemorrhages seen in the retina. In all the quadrants it was seen, and OCT showed mild hyperreflectivity in the inner retinal layers, and there was no macular edema. And on systemic examination, her blood pressure and other system examination were within normal limits. She had pallor. We have sought physician and cardiology consultation. And on arrival of the blood report, she was found to have anemia with low HB of 8.2, reduced PCV, MCV, MCH and MCHC. And her total count was normal, ESR was elevated and platelet count was 3.1 lakh. And since peripheral smear also showed microcytic hypochromic anemia, her cardiology evaluation and carotid Doppler were normal. Her fasting sugars, fasting lipid profile, renal function, coagulation profile were normal. And since she was a young patient, we did the panel for young occlusion, and all of this hypercoagulable state profile came to be normal. So we made a provisional diagnosis of impending CRVO, most probably secondary to anemia. And she was started on Nepafenac eye drops, and anemia correction was started with parenteral iodine sucrose 100 mg. IV infusion was given once in 2 weeks, and tab equaspirin was started as advised by the cardiologist. And she was reassessed after 10 days. The fundus was becoming normal. The disc hyperemia has reduced. The vessel caliber has reduced. The peripapillary hemorrhages resolved, and few blot hemorrhages were presenting. And her visual acuity also improved to 6 parts and near vision N6 parts. And she was advised to continue parenteral iron supplementation. And she was on follow-up. And this was the OCT in which the inner retinal layer edema is resolving. And then 4 weeks later, she noticed sudden drop of vision in right eye on waking up, And her best corrected visual acuity in right eye was 636, N36, left eye was normal. And on examination, right eye anterior segment was normal. There was no angular iris neovascularization. Intraocular pressure was 15 millimeters, left eye was normal. And fundus revealed again a hyperemic disc with multiple peripapillary hemorrhages, increased venous caliber and tortuosity. And OCT showed presence of fluid. And at this stage, she was on having parenteral iron supplementation, and her hemoglobin has improved at that stage to 9.9. And she was started on calcium dorbicillate, continued iron sucrose. We advised FFA at this stage, but the patient wanted to wait. And 2 weeks later, it came as a full-blown occlusion. But at this stage, her visual acuity was improving and the patient was happy. And on OCT, the retinal fluid has reduced. And then we kept her on observation. It's going. And 8 weeks later, she reported back with a best corrected visual acuity of 6.9 parts, N12, left eye 6.6, and anterior segment was normal with no evidence of any neovascularization, and pressures were normal. And her fundus showed normal disc, and vessel caliber, venous dilatation and tortuosity has reduced. The hemorrhages has resolved. There were few X-ray near the macula, and OCT showed normal foveal contour and intact outer layers. And at this stage, her hemoglobin was 11.1, and she was on oral iron supplementation. So my question is, actually, this iron deficiency anemia can cause central retinal vein occlusion, but usually it is at a very low level of hemoglobin. This patient was having a hemoglobin of 8.2 at the first stage, and then 9.9. Again, then also she developed moderate anemia. There are very few case reports of central retinal vein occlusion. So anything, am I missing anything else? And would FFA will help in the diagnosis at the time of reocclusion?
Yes, anemia causing vein occlusion is not a very common cause that we see. But if you ask why did it happen at 9.9, actually this impending CRVO is not a term that is used anymore. Now it is when you have a few hemorrhages, disc edema, and you think it with venous tortuosity, then it is a non-ischemic CRVO. You can call it an early non-ischemic CRVO, which may progress later. So it is basically a non-ischemic CRVO with vision good, not much macular edema. And the 9 point, Hi-Ray has showed how the thrombus can progress inside the vein and then convert we know that there is about 18% chance of conversion to ischemic CRVO. All non-ischemic CRVOs can convert to ischemic CRVOs. So some amount of thrombus progression, once it has occurred, will be there. So it is not like the patient developed a recurrent CRVO. The CRVO was there. That CRVO, the thrombus has progressed and become more severe. That is what has happened in the patient.
Yeah. In between, actually, her venous dilatation, that stagnation has reduced. And again, it developed. That was the confusion.
I would actually send her to a hematologist for a full workup, just in case we have missed anything. Cardiac, she has already
Yeah, her electrophoresis was also done. It was also normal.
normal.
And reticulocyte count was reduced, and there was no other blood malignancy. There was
There are
nothing.
some case reports of anemia causing CRVO, but again, it is not common. So we have to keep the patient under follow-up. But I want to highlight another thing that happened. It happened to me. So the patient came like this 36-year-old patient, very mild CRVO picture, no edema. I sent her with a usual workup. We don't do the entire full-blown hematological workup in the beginning. No protein C, protein S. I just gave her a routine workup and told her to get a physician consultation and everything, and told her to come back with the results, and just started her on an epafenac eye drops. And she came back the next day with a combined occlusion. The next day with combined occlusion of artery and vein. And then then they were like very agitated because they had, this is like many years back, 10, 15 years back. They were very agitated because we came and saw you, doctor, and you did not tell us that she's going to lose vision, and you did not do anything. But again, it's not something I could have prevented, even if I had sent some investigations. It's not something we could have prevented. But I want you to warn the patient that it can increase. So this kind of like when it comes six ഇപ്പോൾ ഒന്നും ചെയ്യണ്ട കുഴപ്പമൊന്നുമില്ല ഇങ്ങനെ കാർഡിയോളജിസ്റ്റിനെ കാണൂ അവരെ കാണൂ ഇവരെ കാണൂ, they think we are avoiding them. So that has to be conveyed very clearly that you have a problem, we are trying to get to the bottom of it, but it can increase, and if it increases you will require further ocular intervention. That patient had APLA. She was APLA positive. She had a bad obstetric history. So again, young patient comes to you with CRVO, lady, ask for the obstetric history. Immediately send the APLA. APLA takes 5 days to get the result. So if you can send it on the first day itself, by the next review, you will have the result with you. Other common thing that we miss out is homocysteine. Serum homocysteine, raised homocysteine can cause CRVOs. Other workup, of course, if you don't get hypertension, is increasingly the cause for CRVO in younger people, because all 30s people have hypertension now. So that again has, and they will deny it, absolutely no BP. So you have to send to a physician. That could just be the cause. Otherwise, a full workup. The other one is a vasculitic workup, the one aspect that you have not done here because the fundus does not look vasculitic, but that is another workup that you can do for the you have sent the ANA, I think ANA PLA was also
ANA,
done.
and at the time of second time we sent for the whole connective tissue panel as advised by physician. Everything was negative.
It's worth going the whole way with young CRVOs because you will be saving their lives.
Yes.
Thank you, Dr. Paril.
Okay. So just I want to send, there is no definitive treatment guidelines for young patient with CRVO, but it is similar, essentially similar to elderly with injection if there is any vision loss with macular edema, and condition that may predispose to younger patient to CRVO carry significant systemic mortality and morbidity and often require further investigation. So we have to do a proper systemic workup and treatment of the predisposing conditions.
Anemia may not be the reason for CRVO here, because for the CRVO to occur, you should have two things. One, there should be alteration in the blood circulation. Other reason is blood vessel abnormalities. Anemia cannot cause both these things.
Yeah.
Yeah.
Some case reports are there. In moderate, most cases it will be in severe.
Madam told we have
anemia.
to work more on vasculitis or something.
Okay, thank you, ma'am.
Next, I call upon Dr. Anju Kuriakos, who will be presenting on resolving the IRBAN quantum.
So good afternoon to one and all present here. I am going to present a case of a 28-year-old man presented with blurred vision for 2 weeks. He is not giving any history of headache or vomiting, no history of trauma, no comorbidities, or not on any medication. On examination, his vision was 6/6, both eyes, anterior segment with within normal limits, and IOP was within normal limits. Next is fundus examination of the right eye, showed cleared media, tortuous vessels over the disc, and exudates paranasally with peripheral sheathing of vessels. Fundus of the left eye showed similarly clear media with tortuous vessels noted over the disc, with exudates in the parafoveal region with a macroaneurysm inferior to the fovea. So this is a montage picture showing peripheral sheathing of vessels in all 4 quadrants in both eyes. So this is an OCT picture of the right eye showing normal retinal layers, and octa picture of the right eye disc showing disc aneurysms, and octa picture of the macula showing normal FAZ. So left eye OCT macula showing normal retinal vessels. This is the OCT picture corresponding to the macroaneurysm, which is showing diffuse thickening of the retinal layers with hyperreflectivity with backshadowing suggestive of exudates. This is an octa picture showing disc aneurysms, and OCT octa picture of macula showing normal FAZ. This is the octa picture corresponding that macroaneurysm in his left eye. So with this was the first examination. With the examination and the history, we have come to a differential diagnosis of optic disc granuloma with vasculitis, VHL disease, retinal artery macroaneurysm, Coats disease, or IRWAN. So we went for the basic workup with uveitic workup with chest X-ray, ultrasound abdomen, since we are seeing macroaneurysms, and carotid Doppler, which was found to be normal. Next visit was his FFA, which showed right eye showed the area of hyperfluorescence over the disc, which was increasing in the late stage with diffuse leakage. This is the left eye fluorescent angiography showing again the diffuse leakage in the late stage along with the leakage from the macroaneurysm. This is a montage picture showing extensive CNP areas in all 4 quadrants. So we started him on oral steroids, and after he was followed up after 15 days with no complaints, but after 3 weeks he came with complaints of seeing black spots in his left eye. Even at that visit he had vision 6/6, anti-segment normal, and IOP was also within normal limits. This was a picture at that time. Right eye was similar, but left eye showed opacification of the retina in the inferior parafoveal region close to the macroaneurysm, which was increasing in size. This was the OCT at that time, which shows hyperreflectivity of the middle layers near the parafoveal region, suggestive of a PAM lesion. As you can see, this is corresponding OCT taken corresponding to the macroaneurysm, which has increased in size. So this is the fundus picture is the first visit, and this is the fundus picture in the second visit. We can clearly say there is opacification of the retina with the increase in the macroaneurysm size. So this was the size of the aneurysm in the first visit, 333, and the second visit is 586. So this was the OCT in the first visit and the OCT in the second visit. And this is the OCT of the aneurysm in the first visit and second visit. In the second visit, we can see the microaneurysm size has increased with diffuse thickening of the retina. This is the octa corresponding to the second visit, which is showing the enlargement of the FAZ zone, which is corresponding to the PAM lesion. So at that time, we have done the HFA and neurological workup. From based on the workup and the literature review, he was diagnosed to have IRWAN, idiopathic retinal vasculitis, aneurysm, and neuroretinitis. In view of increasing size of aneurysm and PAM in OCT, intravitreal anti-VEGF was given, followed by an FFA-guided PRP was done in both of his eyes. 1 month post anti-VEGF, we can see the gradual resolution of hyperreflective lesion along with the progressive thinning of the OPL and IL, partial collapse of overlying retinal lesions leading to irregular foveal nomenclature. So this is the size of the aneurysm with the corresponding OCT. This is first visit and this is second visit. The PAM lesion. This is third visit post injection. So this is a post PRP picture. FFA guided PRP was done, and this is 6 months follow up in which we can see the aneurysm has totally disappeared from the left eye. This is a OCT of the 6 months follow up, resolution of hyperreflective lesion with severe thinning of OPL. In this picture, we can see there is no aneurysm noted. This is the first visit, second visit, third, and fourth visit. So what is new about this case is paracentral acute middle maculopathy, that is PAM with IRWAN, was reported by us in the literature to the best of our knowledge. Vascular occlusion might result from disrupted blood flow associated with the macroaneurysm. In our case, dynamic change in the size of the aneurysm was probably led to the localized vascular compression causing the PAM. So my questions are, how will the oral steroids alter the clinical picture without the systemic treatment? Because we had started the oral steroids before the FFA, after the initial workup. Yes, like we haven't started any other treatment. We didn't do any PRP, FFA. Before starting the FFA, we had done the we had started the oral steroid. Will that alter the clinical picture?
Definitely alter the clinical picture because IRWAN is retinal vasculitis. So there is an inflammatory component there that has caused all these findings. So that inflammation is going to come down with your oral steroids. So did the increase in the aneurysm size occur after you tapered the steroids?
No, when he was on tapering of steroids after 3 weeks.
Okay, because Irwan, Irwan is a diagnosis of exclusion. You cannot diagnose Irwan in this patient without ruling out all the other causes of vasculitis, especially sarcoidosis and tuberculosis. Because the secondary aneurysm formation that has occurred here can occur in any vasculitis. So we cannot, idiopathic retinal vasculitis, for you to make it that idiopathic, you have to do the full uveitic workup and then put the patient, if needed, on steroid and immunosuppression. Yeah, our topical treatment, our local treatment will be only adjunct to the systemic treatment, especially since both eyes are involved.
No,
only one eye is
one eye, aneurysm was there only in one eye.
only in one eye. Okay.
So
Your other differential diagnosis will be adult coats also. You can
Yeah, it
get
is.
multiple aneurysms in adult coats. That's another list. Did you have any vitritis? I thought in one OCT, what was his floaters because of vitreous hemorrhage?
no, he was seeing only black spot, like one scotoma
One
like thing.
scotoma.
Scotoma like thing.
Okay. One of the OCTs is showing a little bit of a vitreous dot just over that aneurysm. Just go back to your OCT, I'll show you. Previous, one more before. No, this is the beginning, no? It's inflammation there. Okay, that's not a very common disease. Does anybody have any questions?
I have discussion should.
You have one more. Oh, discussion.
Discussion.
Okay, go ahead.
So second question was, given the extensive CNP areas and peripheral sheathing of vessels, should we further do a vasculitic workup?
The vasculitic workup should be done in the beginning. You cannot give a diagnosis of Irwan before you do the vasculitic workup. So the CNP areas have nothing to do with it. CNP areas will be there in any vasculitis. If it is an occlusive vasculitis, has to be treated with PRP.
So after seeing that PAM lesion, should we treat with anti-VEGF right away, or should we observe, or is observation a reasonable first approach?
Not observation. I would have given the patient systemic steroid plus immunosuppression and then watched what is happening to the microaneurysm, given PRP if this thing. Anti-VEGF to reduce, even in macroaneurysm, anti-VEGF is not really indicated. So I wouldn't have jumped to anti-VEGF, but you've got a good result. So.
So discussion, it was first described by Chang et al. After a series of cases, isolated retinal vascular disease that can progress rapidly to severe vision loss due to ischemic changes. So it includes diagnostic criteria, which includes major and minor criteria. Major is retinal vasculitis, aneurysmal dilatation, neuroretinitis, and minor criteria includes peripheral capillary non-perfusion areas, retinal neovascularization, and macular exudation. So new thing has come. Is there a true neuroretinitis in Irwan? Neuroretinitis has been considered as a prominent feature in Irwan, diagnosed with the late optic disc staining on FFA. However, patients with Irwan syndrome will not usually doesn't present with an alteration in the optic function, visual function, consistent with an optic neuropathy. So the typical stellate exudate maculopathy seen in Irwan is primarily caused by the leakage from the retinal arteriolar aneurysms at or near the optic disc, which could be misinterpreted as a feature of neuroretinitis. From that study, they have concluded there is no clinical evidence of true neuroretinitis at any disease stage in patients with Irwan syndrome. So they have proposed a better acronym, that is IRVARE, that is idiopathic retinal vasculitis, aneurysm, and retinal exudates is proposed to better characterize the syndrome. So multiple imaging modalities are used. OCTA can be used as a complementary tool to FFA in the diagnosis and to assess the progression. So what is this middle maculopathy? Paracentral middle maculopathy is deep capillary ischemia in the acute phase, can be recognized by a characteristic hyperreflective lesion at the layer of INL referred to as paracentral acute middle maculopathy. Thank you.
Now I would like to call upon Dr. Natasha, madam. She needs no introduction. The full hall says it all.
That's
Okay,
not
she'll be
me.
talking on diabetic macular edema.
I think this is the most accessible hall probably. Just everybody just walked in. So this is after the two relatively rare cases, we go to the most common case that we see in our medical retina OP, which is diabetic macular edema. So I'm just going to present two cases and then we'll jump into the discussion. So this case is a both eye severe NPDR with diabetic macular edema presented to me with 618 vision in the left eye. He was the uncle of the colleague of the hospital where I'm going. So I advised him the high-end intravitreal injections and he decided on brolucimab. So I was very pleased because he's going to get a good result is what I thought. But after 4 injections of brolucizumab, this is his macular edema on the other side. His vision has just improved from 618 to 612 parts and I was left feeling like a little bit of a fool. And due to the lack of response to brolucizumab and also because of the development of cataract, then I advised thought of switching to the steroid group and combining a cataract surgery. My aim was to give him a little bit increase in vision. So let's put in some Ozurdex and let us send him for a cataract extraction. So I sent for that and the edema had decreased some extent and the patient was taken up for cataract surgery and was good after cataract surgery. But immediately as the Ozurdex effect went off, the edema came back. Now this time he didn't want repeat Ozurdex, he didn't want brolucizumab, he said already I've spent too much money, I don't want any of that, I want the lower anti-VEGF, and he chose a biosimilar. And 4 injections of biosimilar later, he is still at his macular edema, you can see it is still up there and his vision is at 612. So that is one patient. This patient came to me with PDR with a very mild edema. I advised him an angiogram, but by the time he came for the angiogram, his edema had increased. So I advised him injection followed by cataract surgery, followed by a PRP. And after the first injection, ranibizumab, and he underwent cataract surgery, edema had decreased, underwent cataract surgery, very happy, his vision was good. I gave him a first sitting of PRP and then the edema came back like this. 2 weeks later he calls me saying, ഭയങ്കര ബ്ലറിങ് സാർ മാഡം എനിക്കൊന്നും കാണുന്നില്ല ആൻഡ് വെരി വെരി അൺഹാപ്പി ആൻഡ് സോ ഐ അഡ്വൈസ്ഡ് എ റീ ഇഞ്ചക്ഷൻ ഐ ഹാഡ് ഓൾറെഡി ടോൾഡ് ഹിം ദാറ്റ് ഇറ്റ് മൈറ്റ് ബി റിക്വയർഡ് ബട്ട് ഇറ്റ് വാസ് വെരി മൈൽഡ് edema. First injection it went off, so I didn't really give him a very grave prognosis that he will require a lot of injections or anything. And then he was very unhappy and you can guess what he did. So he went to another hospital and so that's what happened. So this is what often happens to us. So one term that we should know is refractory macular edema is when your injections have not given you more than 5-letter improvement or a less than 10% decrease in the CST. Lack of treatment response when you have given 3 anti-VEGFs and there is persisting or worsening of DME and non-improvement of functional and anatomical outcomes. Now what affects the treatment response? The better the baseline characteristics, the better the response. Baseline visual acuity, age of the patient, chronicity of the edema, absence of ERMs, the grade of the diabetic retinopathy, more CNP areas means more contribution to the macular edema. Vitrectomized eyes and associated systemic status. We also know OCT biomarkers can help us predict. The ones that help our SMD responds very nicely, vision will improve. Integrity of the ISOS and the external limiting membrane, if it is there, it will improve. The high reflective foci, if they are lesser, it will improve. And drill, if it is there, higher the drill, lesser the improvement. And presence of any vitreoretinal interactions can cause a decrease in the effect. But all of this are just studies and they're not predictive in a single patient who comes to you in your OP. Now, how do you manage a refractory DME? You have to correct the systemic factors. You can change the class of the anti-VEGF, advise a different anti-VEGF. You can change to a steroid. And so for my discussion with you, I would like to consider these questions. In your practice, when do you consider switching of the intravitreal agent? Do you do it after the first injection, second injection, third injection, or you just give up? Just give me your response. Do you do 1, 2, or 3? 2 injections, madam. PSG madam says 2 injections. Anybody else? In diabetic macular edema, what do you expect to happen after 1 injection? 5-letter improvement in after one injection. Yeah. About 100 micron decrease in the edema, and about a 5-letter improvement, maybe just a 1/2 line improvement in your Snellen acuity. But so generally the refractory DME definition is 3 injections of anti-VEGF. So you can wait for 3, and if you are absolutely sure it's not budging at all after the first and second injection, then you can shift in the second injection itself. The second one is, how good control of systemic factors do you need for starting treatment? Do you wait for the HbA1c? So I have staff calling me and saying, "Ayyo, madam, naala injection vechirikkuva patient HbA1c 9." So HbA1c 9 inject cheyo. Yes, it is only a day-to-day control of sugars that we require. We should have a fasting sugar less than 150 preferably, and a ppbs less than 250 before taking up for injection. It is not required to get the HbA1c under 7 for you to start treatment for DME. It's never going to happen. So your day-to-day sugars should be controlled. Fasting sugar should be controlled when you take up for injection to prevent the infection risk. It really does not have much action on the result of the injection. But when do you say that, okay, I'm going to wait for systemic control, I'm not injecting this patient? When you have bilateral SMDs, a recent worsening of vision, a patient says that he has been admitted in the hospital for some surgery or for a foot infection, something that has recently worsened his systemic status. There, your patient has come with the increase in the edema, severe macular edema with some SMDs. If you have submacular detachment bilaterally associated with some systemic status worsening, it is worth waiting for a month to get that under control. Send a letter to the physician saying that he has worsening of his macular edema. A worsening renal function again can cause. But you don't have to wait for more than 1 month. There is no contraindication for injection, but recent worsening in the vision with a recent history of a systemic admission for some aggravating factor of his diabetes, it is worth waiting for 1 or 2 months till that gets controlled. It actually reduces just by the control of the systemic factors alone. Anything else that you have found in DME management? One is to look for pioglitazone in the number of drugs they are using, but very rarely they use it now. So, and the other thing is, with the trade names, you really don't know which is the pioglitazone in that anyway. So that is a very difficult thing to find out. But anything else? Anybody in the audience has anything to share?
One thing which causes worsening of DME is this blood sugar when they go in for hypoglycemia and then hyperglycemia.
The brittle blood sugar.
Brittle blood sugar. If it is little higher blood sugar, if they are like 150, 160, that has better prognosis than having one day they are having 70 and next day they are having 150. That causes more macular edema and more this thing. So that we have to discuss with the physician and ask them to reduce their insulin dosage.
The last question, I think we are bang on time. Last question, how many of you are using the newer anti-VEGFs, aflibercept and Vabysmo, faricimab? Hands up, please. Yes, Simi. Yes, ma'am. What is your experience with the newer anti-VEGFs? No commercial interest here. It's just a discussion because people should be aware of the newer anti-VEGFs. Ma'am, what is your experience, ma'am? Have you got a good result? Do you feel that it improves our results? Edema-free intervals, yeah. So that is something I want to introduce, that everyone should start using higher anti-VEGFs in higher means higher cost anti-VEGFs in patients who can afford it, because it has really changed the management of DME, at least in my practice. I don't know if any Roche person is here. He should be at home with some flowers by now. But no, this is no commercial interest. But with the advent of the new drug faricimab, and also with our older drugs that we had, aflibercept, switching from ranibizumab to these higher agents definitely gives a good result in DME, and we get a very large interval of time before giving your re-injection. You have to still advise re-injections, but definite differences there, I would say, especially with the latest entrant into the group, which is faricimab. So that is all I wanted to say. Any doubts? Any questions? Faricimab approximately costs around to the patient around 75,000. Varies between 75 and 80 between hospitals. But they give 1+1, so the next one you can charge just the procedure fee. So in Chaitanya we have 77 to start with, and then only 5,000 for the next injection. So thank you all for the physician fitness before the anti-VEGF. I think it entirely depends on your practice. In a multi-specialty hospital, unless the patient has a definite cardiac stroke or liver problems or a foot infection, we did not take in Amrita. But now that I've shifted to primarily eye hospitals, I take a physician fitness. That is just to be safe. In case something goes wrong, patient develops something, then just to be safe, that's all. So depends on your practice. If you're practicing in eye hospital, I would advise you to have a friendly physician to whom you can send your fitness. But the problem with sending for a physician fitness is that most physicians do not know what fitness they should give. So do you need the HbA1c down to 7? So in your fitness letter, it is better to say that I would like the sugar to be under control. If you're suspecting a foot infection, you can write that I would like to see that there is no infection in the foot. Angane specific aayittu ezhuthi kodutha, you will get a better response from the physician. And I also add in my fitness paper that there is no requirement to stop antiplatelets for this procedure, because that is the next thing they'll say, "Ayyo, aspirin nirthan pattathilla." We don't need aspirin to be stopped. So that you can convey to the physician. Okay, I think with that we'll wind up the session, and I'll not stop you from lunch. Thank you all for being here.